Good morning. You're now listening to Kingston Community Radio, airing on FM 92.5 and AM 920, WGHQ, Kingston, New York. This programming is brought to you by our listeners and corporate underwriters who are interested in presenting local community radio. The opinions expressed on this program do not represent those of Pamel Broadcasting or Kingston Community Radio. Listeners are encouraged to send in $10 per month to help bring this program to you. And please mail your contributions to Kingston Community Radio, Post Office Box 4364, Kingston, New York 12402. For more information or to donate online, visit our website at mykcr.org. And good morning. This is Dan Gatis, bringing us into a new week, and it's kind of a new day. It looks great outside right now, and we're going to enjoy it, even though it's a little chilly. Chilly like 31 degrees. It's Monday, April 11th, and we'll be right back after these messages.
We are Lions. We bring hope where it's needed. We are a global force for good. Support causes that matter. Change lives. Change communities. Change the world. We can do more together than we can alone. Join in. Experience the joy of serving. Be part of the movement. Give back. Let's unite the world for good. We are Lions. You can be too. Visit weserve.org.
Pick up the phone before you pick up the shovel and call 811. It's for your safety and it's the law. Central Hudson reminds all homeowners and contractors, call Dig Safely New York at 811 before digging or excavating. Call this number at least 2 business days before breaking ground. It's a free service that marks the location of underground gas, electric, and other utility lines. Before you dig, call 811. At Central Hudson, safety is our highest priority. That's why we ask you to keep a clear path to electric and gas meters and eliminate all obstructions, including snow, ice, vegetation overgrowth, storage boxes, garbage, or any other kind of debris. Access to meters is important for safety inspections too, and failing to provide access can result in fines. For more information, visit the safety section of centralhudson.com.
Hi, this is Dina Roy from Hurley, and I support the Kingston Community Radio, and so should you.
And we're back, and thank you for being with us and sharing the morning with us and being a fan of community radio. And this is Kingston Community Radio, AM 920 and 92.5 FM, and streaming online at mykcr.org. And community radio is talk radio. So 331-9255 is your call-in number, 331-9255. Love to hear from some of you folks for the first time. Sunshine to start today, then a few afternoon clouds. Way slight chance of a rain shower later today, with a high of 61. So we're going from 31 to 61 today, and rain showers this evening. 40% chance of that, with overcast skies tonight, with a low of 46. And Tuesday, a high of 70, and 60% chance of rain. And early with some sunshine later in the day, though. A few clouds on Tuesday night with a low around 40. And then Wednesday, 69 degrees is the high. And a very, very slight chance of a rain shower. And a high of 69 for Wednesday. Sounds good. It's going to be cloudy. And overcast with rain showers at times. 50% chance of rain showers on Wednesday night. And you are listening to KCR, and this is a Medical Monday, and we're all here. And Dr. Eric Stanberg is all here too. That's one way to say it.
All right. Well, good morning. Yes, we are all here. Welcome to this morning's show, April 11th. A little chilly than we would expect it to be this halfway through April, but it's going to warm up this week.
We were up in...
Wait, go ahead.
Crazy. We were up... we have a property up in on Lasher Road up in Big Indian. And we went up to see, what kind of maybe flooding was happening and stuff. That was all good, but it was snowing. It was snowing.
And the flooding's amazing. Down
low, yes.
I'm in Tilson, so we go right over the Rondout Creek, and
Right.
I guess the history, maybe some listen, but I guess somewhere in the 70s, the Army Corps of Engineers came in and built up that area so to prevent flooding, and it does a pretty good job. But a little bit to the south in New Paltz, the Walkill, on the west side of 32,
Yes.
it always floods and kind of.
It did.
Yeah.
And it did quite successfully.
Quite successful
Yeah.
flood.
Yeah.
All right. Well, welcome to this morning's show. We'll be here till 9 a.m. Our phone number is 331-9255. Robin will be joining me. We have a guest calling in at the 7:15 time slot. And boy, do we have time slots? I guess we do.
Yeah, from break to break, I guess.
All right. I'm very excited to have him call in. His name is Dr. Michael Stern. He is a urologist. A lot of times, people think I'm saying neurologist or the other way around, but urologist begins with a U. And he practices in Kingston, and I think he practices out of another town. He'll tell us about it, but he's part of Premier Medical Group. They have an office over by the former Benedictine Hospital campus, and they really, provide excellent services to our community. So I'm very excited to have him on, and we're going to talk about various topics. So what is a urologist? A urologist is a medical a specialist in diseases of the urinary tract, which is kind of start from the kidneys, and then you have these things called the ureters that drain the kidneys into the bladder, and then on its way out, that's called the urethra. So men and women both have this. A urologist also specializes in male diseases of the genital tract. The prostate problems, even testicular problems like testicular cancer. So they really provide a very important service, and they're surgeons. So it's a surgical specialty as well. They do a lot of work in the operating room. So common reasons that someone would go to a urologist, I just kind of jotted a few down. Workup and treatment for things like kidney stones. A topic that comes up a lot for me in the office is blood in the urine. We call that hematuria. Hematuria kind of has two forms, that which the patient notices. They go to use the restroom and they notice that there's blood in the urine, or blood that, in a way, I notice. We do a sample in the office and we analyze it and there's blood in it. Cancers of the urinary and male, the urinary tract and the male genital tract. So that would include kidney cancers, bladder cancers. It includes prostate cancer. It includes testicular cancer. I'm probably missing a few. A very common condition that a lot of men have is called BPH. That stands for Benign Prostatic Hypertrophy. As a man gets older, the prostate gets bigger, and it starts to potentially cause some urinary problems. Very common problem. Male fertility problems are in the domain of the urologist. And even some more male sexual dysfunction problems are also, if a specialist is needed, in the domain of a urologist. It's a little bit of other doctors can treat this too, but things like testosterone problems. Let me see if I'm missing anything here. I think I covered a lot right there. But anyway, really, when I analyze my own referral patterns and what are the most common types of physicians that I send, that I refer a patient to, a GI is usually, gastroenterology is usually number one, but there's a very good reason for that, and that's colon cancer screening. So if you take away the colon cancer screening, it's kind of a toss-up for other specialties, and urology is definitely in the top 5 for me. I feel like the top, real radio now. The top 5 could do a countdown,
Yeah,
like Casey Kasem or something. Anyway, so that's it. So a lot of people are they're confused. Patients don't always know where to go, and that's one of the things that a primary care provider can help you with. Very common. Just recently, things like knee pain, arthritis in the knee, they'll say, I should go, my friend told me I should see a rheumatologist. And the answer is probably not. The answer is more of an orthopedist. Likewise, you have a problem with your kidney, you should see a nephrologist. And then understand there's a crossover with these two specialties of nephrology and urology. But a nephrologist is a specialist of medical diseases of the kidneys. For example, even though a urologist would work up blood in the urine, sometimes it's a medical problem. So, and then a nephrologist is important. So it's always, I don't know. Sometimes patients are, even though they're in this kind of consumer-oriented healthcare system, and they're put more and more in the driver's seat, they don't always really know which exit to take on the throughway, if you know what I mean. That's a good metaphor.
We'll keep that for the books.
That's right. Anyway, he's also a young physician. Some I always say to my patients, someone who was trained in this century. That always kind of makes the point. But it's always a delicate balance. Medicine's ever changing. The change in practice in just 5 to 10 years. So even though it's good to have a more experienced physician who's been doing it longer, there's newer things, new perspectives. So don't always shy away from a newly minted physician. In many respects, they're very well trained and maybe even more abreast on the current recommendations for a medical problem. That's some other advice I have for people. By the way, we have a very high standard of medicine in our country. I'm not judging other countries, okay? But if someone went to medical school, did a residency, gets licensed, something called board certification is pretty much universal now. There was a time where board certification was kind of almost optional. It was a way to, in a way, increase your marketing towards a potential patient. I'm board certified in whatever field, but now it's really required. So in addition to doing medical school, a residency, passing licensing exams, a physician has to become board certified in order to basically practice. So our standard of qualifications in the United States is very, very high. And again, I'm not judging other countries because I don't know enough about them. I think it's equally as high in Canada. My guess is it's in other parts of the world as well. But just remember that you don't just become a urologist because you felt like painting that on your shingle. you went through a long treatment for that. So anyway, look forward to having him call in, and we'll talk about various reasons. So I think that's a nice introduction. So anyway, other topics we're going to touch in the time left over. We're going to do our annual Lyme disease review. I don't hear as much about Lyme these days. It's almost like the anxiety of it has been replaced by anxiety of COVID.
Yeah, that's very true. However, we're just coming into the season for it. We are obviously just coming into the season for it, and I've gathered a couple ticks already between me and my dog.
That's it. You can start singing a country song. What are you going to say?
Yeah.
Me and my dog.
Me and my dog.
Lyme disease. But many of us adopted some good habits in our COVID existence, of getting outside more, going for walks and things like that. So I felt it was timely to bring it up. And I think it's also, if time allows, we'll do another one of our seasonal reviews of other ailments of spring and summer, which is just poison ivy is worth talking about. Okay. And then we'll touch a little bit on COVID. I know people are like, they'll say they're sick of COVID. Look, I'm sick of it. I think people are sick from it and they're sick of it. So, and I look forward to not having to discuss it. But there's a slight uptick. And the good news is that, might be very preliminary, but people seem to be handling this just fine. I worked at the hospital over the weekend, and we did have I had to admit a patient who was COVID positive, but those were not her symptoms. She just was positive, so she was sick enough to be admitted to the hospital, but probably for other reasons. Interesting.
It's diluting to some extent, right?
Yeah, I don't know if you remember when we had Dr. Froud on, but he talked
indeed.
about that. Basically these this idea that the virus wants to live. Yeah, a little bit. So it wants to mutate. To use, for whatever, if that word's
Yes, exactly. And
accurate.
yeah, I saw him about a week and a half to 2 weeks ago, and we talked about the efficacy of that theory and how well that played out. It's playing out.
Yeah, and I've become quite an authority on the Russian flu of 1898. But he talked about how the flu was analyzed. It was not a flu; it was a coronavirus. So you can learn a lot by studying that outbreak. It's interesting because outbreaks were different because people didn't travel as much. But on the other hand, they kind of, if they were in a city, they spend more time closely together. All right, so here's our guest calling in, I believe, right now. All right. How we doing? All right. So, good morning. Is that Dr. Michael Stern?
Yes, this is.
All right, great. Thanks for doing this.
Well, thank you for inviting me.
All right, great. Now, in the weird COVID era, you and I have not had a chance to meet, but I have really benefited from your services for my patients, and your colleagues as well. You really have a very important practice in the Kingston medical community and provide a lot of necessary services to the patients. So thank you for that.
Oh, thank you.
So how long have you been practicing here?
So it's a little under 2 years. I joined in July of 2020.
Okay. And we I would start when I have a guest on. I like to interview a little bit about you, like where you're from and where you trained, and how you ended up in the Hudson Valley. Where were you a native of?
Yeah, so I'm initially from Brooklyn, New York. I grew up. I went to med school at downstate, also in Brooklyn, and then I did my residency in urology at Westchester Medical Center. And then right after graduating, I moved up here. I live in Beacon currently, so I practice both in Kingston and also in New Windsor in Orange County.
Yeah, so you're seeing patients in Kingston. Are you also seeing patients in another community?
Yeah, so I split my time. I probably have a little more office hours in the New Windsor office, but I'm here in Kingston twice a week, and then 2 to 3 times a week I'm down there.
Okay, and when you have to operate, what hospital or surgery center do you work out of?
So I work out of 3. So Kingston Hospital, and then also St. Luke's, Cornwall, in Newburgh. And then we also have a surgery center that we do outpatient cases in Poughkeepsie called the Dutchess Ambulatory Surgery Center, or DASC.
Okay, great. So, I was doing an introduction here, and I was kind of saying how your urology. I always have to emphasize the "ur" because people think they're going to a neurologist. It's probably in my top 5 of reasons to refer a patient to a specialist, and I was kind of jotting down common reasons. Are there any within your specialty? Are there any specific areas that you focus on, or that you actually enjoy doing the most?
I kind of see a little bit of everything in terms of urology. So, one of the most common things I probably see is kidney stones. So, those are, obviously, big. Women who've given birth will say that having a kidney stone is more painful than giving birth. So it's definitely a very bothersome issue for a lot of patients. 10% of people will have a symptomatic kidney stone at some point in their life. So, a very common thing that we both evaluate for. Those surgeries I enjoy. We also talk about prevention methods. I put people on medications sometimes to help prevent future kidney stones, or at least some people who keep getting them, minimize them. So it's probably one of my favorite things to treat.
Okay.
And then there's other things are enlarged prostate. So, do various procedures to help quality of life. Some people are, enlarged prostate, if it gets severe enough, some people are dependent on a catheter, and it's always very comforting to get them rid of a catheter. So that's really one of the more satisfying things that we do. And then kind of do a little bit of everything. We treat recurrent UTIs, incontinence is another thing, both in men and in women. That's kind of the brief rundown of that.
Okay. So just, and one thing that's more of a symptom or a sign is, and I was talking a little about this because it shows up in my practice all the time, which is blood of the urine, hematuria. When a patient is told by a physician, hey, there's a little blood in your urine, what does that mean and what should be done about it? I find this a very large topic because it comes up all the time. So I think that might be a good place to start. What do you think you would advise people if they were told that by their physician or healthcare provider?
Yeah. So so first of all, blood in the urine. I heard you mention that there's two types. There's we call it visible, or what's called gross hematuria in medical terms. There's also one that's only visible under a microscope. We call microscopic hematuria. So, anyone with either of the two should really be evaluated by a urologist. So, gross hematuria, we always want to know about the severity. If there's clots, if there's clots and somebody can't urinate, that's more of an emergency. But most of the time, I like to see them on a fairly prompt basis. Usually, different things that can cause blood in the urine. So, definitely something that's on people's mind is cancer. It's only present the minority of times. Wow. Other things that can cause it are, in men, enlarged prostate is a very common cause. Kidney stones or stones in the bladder is another one that can cause it. Urinary tract infections or UTIs. So usually, if somebody has visible blood in the urine, we get a CAT scan to look at the kidneys, look at the ureter, that's the tube that drains the kidneys, and then we do a cystoscopy. It's a camera to look inside the bladder. And then if they have microscopic hematuria, so that's usually, patients come in for either a physical or they come in, or sometimes they, if they come to see me, they'll come in because they have, burning with urination or some other symptom. Usually in the office we'll check a dipstick, and then from there, if the dipstick is abnormal, I'll send it to the laboratory for the technologist to look under the microscope and look for red blood cells under the microscope.
Right.
And then that's actually it's a little more controversial in terms of how aggressive you should be with that. Right. It used to be that we would recommend a CAT scan and the cystoscopy, that's the camera to look inside the bladder, to every patient. It's actually, the AUA, that's the American Urological Association, that's kind of our I wouldn't say governing body, but kind of the group that recommends guidelines for urologists, has actually kind of stepped back a little bit. It turns out that especially for people with like a very slight amount of blood in the urine, that, we were doing a lot of workups, and you definitely find some things, but we're trying to minimize the number of negative workups. Obviously, there's always a balance. Anytime you have a screening test, you want to balance the procedures with the.
I gotcha. It happens. From that, I try to follow evidence-based guidelines as well. Generally, a screening urinalysis is not really recommended anymore. Now, many people still do it as part of their monitoring. And we all have stories of someone who was diagnosed with something that otherwise would have not been detected if someone did not do a urinalysis just for, kind of screening purposes. But the evidence is that it's not. It's kind of the jury's out on whether or not this is something that should be done or not.
Yeah, and I think it's like that with that, and also obviously not to get into a tangent here, but with the prostate cancer screening is another
absolutely
controversy.
We'll get to that because that's a big one. But the take home is if you do have, as a primary care physician, if someone has persistent hematuria or significant hematuria, I refer, or if I say to them in my brain, if I'm not sure what to do next, I'm going to refer the patient. That's one of the reasons for a consultation. If the conclusion is we can just watch it. I love the term watchful waiting. It's used a lot with prostate, but if that's the conclusion, that's okay with me.
Yeah, I think, so one of the changes in our guidelines was that for a low-risk patient, you can actually, instead of getting a CAT scan, you can get a ultrasound of the kidney and bladder because, the number of extra scans the number of extra scans to catch something with the CAT scan for the ones with the, very small amount is really not worth it. And,
right.
There's a lot of costs and, even the radiation, we'd like to try to minimize that if it's not needed.
Just a reminder to people listening as we focus on prevention here, bladder cancer is one of the many cancers that is linked to smoking. It's interesting. Why would the bladder be affected by whether or not someone smokes or not? But right, what's the explanation? There's some toxin that something somehow gets down into the bladder and potentially causes the cancer.
Yeah. So right, smoking has numerous toxins, and then the kidneys. Their job is to filter. The kidneys and liver, they both filter in different ways. So the kidneys filter the toxins, and then basically those toxins, they kind of sit in the bladder and cause changes to the DNA and the cells, and sometimes that can lead to bladder cancer. It can also lead to cancer. It's pretty uncommon, but it does happen. Cancer in the ureter or in the urinary part of the kidney. There's two types of kidney cancers. There's the common type, and then which is in kind of the outside, or what we call the meat of the kidney. But then there's one in the inner part where the urine is. And so people who have exposure to toxins, so the biggest one by far, or the most common one is smoking, and it's, the longer the history, the more the risk with that is. So that's, anyone with a, long smoking history, even with the microscopic hematuria, they all get a workup because they're high risk. Other things that are risk factors, certain, so people who work in chemical plants, I know these days, well, hopefully there's better PPE for employees, but, some of the common, like certain textile, especially dyes, another thing is like people a lot of exposure to hairsprays. That's a common one. So, bladder cancer is more common in men, but I do have patients that are female, and some of them have worked as long exposure to hairsprays or whatever it is. So, if someone does that work, hopefully they're getting some sort of respirators or something to minimize the inhalation of that.
Right. I remember that was always them teaching that in medical school. It was like one of the industries was that I get dyes or cleaning or carpets or something like that.
Yeah. Anything. I mean, there's probably a lot of chemicals. Now like the big thing is people are talking about the PFAS. Are you familiar with that or?
Not really.
So it's like the fluoride byproducts. Like when they make like Teflon and things like that.
Right. I remember now.
Yeah, so that's probably going to be the next big thing if I had to guess. But other things, yeah. So it's really what we call aniline dyes, hydrocarbons. So really any sort of chemical industry, is definitely DuPont's. I think had in the 20s or 30s they had a lot of patients with various types of cancers, not bladder cancer, lung cancer. other things too.
There's probably some commercial running right now. It's saying if
sure
you've been work but in 15 seconds we're going to go to a quick break, but then we'll have you back afterwards. And I think we're just scratching the surface so far. Is that all right?
Yes.
Okay, great. Thanks. This is Dr. Michael Stern, a urologist in Kingston, and I think he said Cornwall?
Yes, St. Luke's, Cornwall.
St. Luke's, Cornwall. All right, we'll be back.
Okay, and we'll have a 3-minute break, and thank you, Dr. Michael Stern, for being with us today. And you are with us here at KCR, Kingston Community Radio, AM 920 and 92.5 FM, and streaming online at mykcr.org. April 11th, on a Monday, Medical Monday, and it's 33 degrees right now here in Uptown Kingston. We'll be right back after these important messages.
At Central Hudson, safety is our highest priority. That's why we ask you to keep a clear path to electric and gas meters and eliminate all obstructions, including snow, ice, vegetation overgrowth, storage boxes, garbage, or any other kind of debris. Access to meters is important for safety inspections too, and failing to provide access can result in fines. For more information, visit the safety section of centralhudson.com. Around any bend in any road, any time of the day or night, Central Hudson crews can be found working in the Hudson Valley, from Montgomery to Millerton, Freehold to Fishkill, and many points in between. We mark our work zones for safety's sake. As a driver, you can do your part too. Slow down, pay attention, put down the phone, and obey the flaggers. Be prepared to stop and maintain a safe distance from the vehicle in front of you. Safety matters.
Hi, my name's Maggie. I'm from Copiague, and I support Kingston Community Radio, and so should you.
And we're back, and you're with us here at KCR, Kingston Community Radio, AM 920 and 92.5 FM, Monday, April 11th, Medical Monday, and it's 33 degrees right now here in Uptown Kingston. It's going to go up to 61 degrees with a little bit of afternoon clouds. Otherwise, pretty sunshiny day, and the high is 61 degrees, as we said. Rain showers this evening is possible. We've got about a 40% chance of rain this evening and tonight, with a low of 46 degrees. Tuesday, 70 degrees is our high, with a 60% chance of rain. So be prepared for clouds and rain. On Tuesday night, a few clouds, low around 40 degrees, and no real precipitation on Tuesday night. Wednesday, cloudy skies, a slight chance of a rain shower with a high of 69. And Wednesday night, overcast with a 40% chance of rain showers at times with a low of 54 degrees. This upcoming portion of Kingston Community Radio is being brought to you by Central Hudson. And let's get back to the on-air studio with Dr. Eric Stanberg, Robin Baker, and Dr. Michael Stern. Welcome back.
All right, thank you. Welcome to the second quarter of this morning's show, and Robin is with us. Good morning, Robin.
Conversation facilitator.
Yes. Robin's job is to make sure we don't get too wonky with our discussion, Dr. Stern, okay?
In the house.
All right. Great.
Make sure that it kind of, we keep it layperson oriented. So we were kind of, we were talking about working up blood in the urine, and then we kind of got onto bladder cancer. I think it's important for people to realize that if bladder cancer is diagnosed in a timely manner, it's actually quite treatable. Would you agree with that?
Definitely, right. So, anytime, usually bladder cancer is picked up. So there's some reverb. So usually bladder cancer is picked up in a workup for blood in the urine. That's the most common way, probably 90% of the time that's how we pick it up. So the way we treat, so usually it's diagnosed with a cystoscopy. That's a camera to look inside the bladder.
Sure.
And then, based on that, usually we'll take the patient to the operating room, and under anesthesia, we'll remove the tumor, which is often both we call diagnostic. We send to the pathologist to look under the microscope and confirm that it's bladder cancer, and that's often even therapeutic. In other words, a lot of times that's all the treatment that is needed.
Sure.
and we're able to do that with basically very small loops, kind of like think about almost like an ice cream scooper, but that goes through a camera that cuts out the tumor from the inside without any external cuts. And from there, we kind of, we do have to monitor patients closely. Bladder cancer, if it's present, does have a tendency to kind of come back. And the things that we look for, or the pathologist looks for, is, there's the more aggressive types and less aggressive types. The less aggressive types, they still have a tendency to come back, but they don't really spread very commonly. So a lot of times, you just have to look in every so often, and just to make, and patients they have bladder cancer, they can live, other than going to the doctor, every so often for the cystoscopy, they can live a full normal life as if that never happened. Sure. And then there's higher grade bladder cancer, which again, it's a little more complex than can be discussed here, but basically you still remove it the same way, assuming it's not, that it's superficial or just on the surface. You can give them some medications inside the bladder, and you watch them, but even that is very treatable.
Here, do we actually have someone on the phone?
The guy is named Steve, and he asked me to run the question down for him. Okay, he was a little shy.
Sure.
So, okay, thank you, Steve. And our question is, or basically a discovery of various kinds of plastic materials, whether it be very, very particulate or a product of plastic cups and plastic bottles, plastics, and how that plays into urology, and what kind of discoveries you have made with that.
Was he suggesting that they might be linked to cancers of the
diseases generally?
Okay. Yeah. Go ahead. Do you have any association between plastic products and diseases that a urologist, under the domain of a urologist?
It's a great question. Unfortunately, I'm not sure if there's really that much data about, a lot of times when you find out about new toxins, things like that, it's not always found right away.
Right.
I wouldn't be surprised if there's some association there.
Right.
I also probably, it's really it's unavoidable, although, I know you can use for cups, you can use aluminum cups or other things too. So, but it's, I personally don't avoid plastics necessarily, but yeah, definitely in the back of my mind, I kind of wonder, what are they going to say in 20, 30 years? I'm not aware of any findings, definitely not with regard to bladder cancer or in general with regard to the effects on the health of plastic, or, I know microplastics are kind of popping up everywhere these days. I think it's definitely a question that, I'm curious if there's, what we're going to find.
Yeah, when for example, I think the connection between a lot of occupational exposures and bladder tumors, wasn't really till the 70s when they were looking back on people who were exposed in the 20s, 30s, 40s, 50s. I mean, it's not easy to reach these conclusions. You kind of have to say, hey, what do all these patients have in common? Oh, guess what? They all worked here, and the cancer rate there is double or triple what it should be. That's really how it's usually done. So you mentioned quickly bladder cancer treatment, about putting medications into the bladder, and I find this fascinating because do you guys still use BCG?
Yeah. So for anyone with the higher risk bladder cancers, we often do a course of BCG. So BCG is it's basically a weaker cousin of tuberculosis, and it's essentially a form of what we call immunotherapy. So you put a catheter into the bladder, you put this BCG, and the immune system recognizes, it's almost like you're giving somebody a urinary tract infection, and it amps up the immune system, and then it fights off the cancer cells there, basically.
Right.
And it's fairly successful for a lot of these bladder cancers.
I think whoever figured this out is a genius.
Yeah, I don't know how. This has been around for quite some time. Actually, some of the difficulties these days that there's a lot of shortages with the BCG, so we sometimes have to kind of lower the dose. Although it seems that the lower dose still works very well.
So BCG is worldwide used as a vaccine for tuberculosis. We don't use it here because tuberculosis is thankfully not common enough. And it's not a perfect vaccine by any means, but in other parts of the world where tuberculosis is so common, it's routinely given. And the fact that somehow by putting it directly into the bladder treats the bladder cancer, I just think is fascinating. We should segue over to the topic, because we're talking about cancer, I guess, the topic of prostate cancer screening. Now, this is something that's been on my shoulders as long as I've been a physician. I was kind of a mid-90s newly minted doctor, and the PSA was out. And I remember urologists were so excited about the PSA and talking about how they're going to be able to screen. And since then, it's been kind of a tricky discussion. How valuable is it to screen for prostate cancer? So I don't even know how to really begin to discuss this topic.
Your guidelines have changed many times regarding this particular subject.
It's gone from being recommended to completely not being recommended, and now it's kind of this wishy-washy. I looked up the recommendation. The official recommendation from the United States Preventative Service Task Force, which is a kind of our Bible of preventive care, it says between 55 and 70, a man in discussion with his healthcare provider may choose to get a PSA as long as he understands the benefits and risks. How's that for a summation?
Is the PSA part of your blood work?
Yeah, it's a blood test, and it's something most of us are, even though we understand the discussion about it, we all have cases in our careers of men who wish they had a PSA done. So it's a very difficult discussion to reach a conclusion. So what's your take on that, Dr. Stern?
Yeah, I think I'm on the same page. So there's really no right or wrong answer. And sometimes, a lot of times patients come to us and they kind of, they want us to kind of make the decision. They're just like, if I go to the mechanic, I don't want to decide what they're going to do with my car, right? So it's kind of the same thing. The patients are coming to us for our expertise.
Right.
So, it's like this controversial topic, and then, when do you check a PSA? Who do you check it for earlier?
Right.
Do you check it, and then how often do you check it, and then when do you go to the next step? So there's really no right or wrong answer. As a urologist, we all have our biases. So the urologist, we see the patient that they get the prostate cancer diagnosis, and sometimes it's too late, and then they never got a PSA, and we're kind of wondering, this could have been prevented. The problem is with these, obviously those anecdotes that kind of impact all of us, and certainly obviously the patient. We do have to kind of take the data into effect, because you can remember the rare, we in med school we learn about all these rare diseases. We call them zebras, right?
Zebras, right?
But if you're supposed to look for the horses. You're supposed to look for the things that are common. So you don't want to. Prostate cancer is a common disease, but you don't want to just if you just have the anecdotes, you kind of can get lost in that chasing these zebras. But with prostate cancer, my opinion is that PSA it's a very easy test to perform. You can throw it in with the rest of the blood work. It's really so it's non-invasive. It's not an expensive test. So what do you lose? I think the problem is when patients have a slightly elevated PSA, that kind of triggers a whole cascade of events that leads to prostate biopsy, and then I do think that probably as urologists, we're probably responsible, for some of this backlash. A lot of people with very non-aggressive prostate cancers have been in the past treated pretty aggressively, with ill effects, and then they're talking about more, you harm more people than you benefit. I think that could be true in certain scenarios where you are, too aggressive. There's a Gleason score, so it starts at 6. So
right.
Gleason 6 is basically like a very non-aggressive prostate cancer. So most of those could be washed. So if you're going to treat all those patients with aggressive surgery and then have complications from that, then yes, it's not worth it. But if you're going to be mindful and triage patients appropriately and not get too aggressive, I think that PSA is very beneficial. So for me, so there's two sets of guidelines. There's the what you call the United States Preventative Task Force, or USPSTF.
Right.
There's also our Urology Guidelines, or AUA. They're kind of, the wording is a little different. It's also kind of leaves it up to the doctor. It's kind of, they use the term shared decision making. They're basically saying that they're basically kind of giving everyone leeway to kind of do what they think is best. And essentially, the most benefit is for patients between the age of 55 and 69. Okay. Above 70, there's less benefit, certainly. And then between 40 and 55, there's also less benefit. Personally, I do typically recommend a PSA. Definitely everyone of 55 and above. I actually, 45 to 50 is when I start. It kind of depends on their family history, risk factors. Right. So it's not rare that, so 50 is where I kind of start, but sometimes I'll even start at 45 depending on other factors.
PSA's covered? Are PSAs covered by insurance?
Well, I could probably answer that, but go on.
Yes, I think for the most part they're covered. Some insurances won't cover them. I think after the age of 70, they also will they'll cover I think once a year, but if it's abnormal and you get a repeat, they'll cover that. So the brief answer is, it's very rare that I have an issue with it not being covered.
Yeah, it has to do with coding, and it's more relevant for what I have to do. When I order a PSA, I have to attach it to a code that says screening for prostate cancer, and when I do that, it does not appear to be a problem. Now, when it's elevated, then it's kind of a different topic. The diagnosis changes to elevated PSA, but it all has to do with trying to figure out the Medicare system, and most insurances will just follow Medicare's lead. But I think I figured it out.
And what about the physical prostate exam?
The famous DRE, digital rectal exam.
I mean,
what do you think? Yeah, now, look, the urologists, they're going to do the DREs. Yeah. What they do. What do you think about the primary care physicians? Should they be doing it? Is it an option? What's your take on that?
So I think that's I think that's even more controversial than PSA.
Right.
A lot of the older urologists say you have to do a DRE on everyone, every 6 months. I think that's a little aggressive. The data indicates that definitely DRE, or digital rectal exam, is helpful for patients with either an elevated PSA or a PSA that's kind of on the borderline. For low PSA, like let's just say PSA under 2, it doesn't seem to add that much information. So, what I tell patients, because sometimes they'll ask me, or sometimes they don't. It really depends. If a patient, has no issue with doing it, I'll do it at least minimum at the initial visit. If patient is hesitant, if their PSA is low, I won't do it.
Right. Okay. But, I don't know if you've heard this, but in primary care, things are very complicated, gotten more complicated. So I have only so much time to do things. So it's something that, for the most part, I have not done as part of my routine examinations on men, based upon, kind of the explanation. But if I'm going to refer a patient to Dr. Stern, he's going to do the exam. I mean, that's kind of the point. He's got more knowledgeable fingers than I do.
Current guidelines, though, that.
Yeah, and look, it's my job to review the guidelines and, stay abreast of any changes. By the way, that idea that if someone has an early mild tumor and we're not going to do anything, that's a very tough sell to patients. It happens in the breast cancer world too, where it's really so mild, it's called a nuisance tumor. The patient's like, what, I have cancer and you're not going to take it out?
Exactly.
It's a very tough discussion with patients. Do you agree with that?
Yeah, I think that, I think there's two ways to approach it. So far, patients have been okay with kind of, when I tell them that it's, very mild, we just have to watch it. We put them on something called active surveillance, which involves usually, definitely checking the PSA a little more frequently. I like to get MRIs of the prostate.
MRI of prostate is a new tool that can be used. That's interesting. That's good.
And then, there's also repeat biopsy. So, when I talk to patients, I think that, I talk to them about what the other options are, radiation and surgery, which, again, those are very effective. But, in terms of some of the downsides, I think that a lot of patients are willing to wait, at the very least.
Do you think men of African descent should be screened maybe a little bit earlier?
I think so. I think, the problem is, again, it's a very broad, category. I'm sure, just because in terms of the genetic variability, there's so much variability that it's hard to know is that really a risk factor overall. But I do think, in the absence of further information, I do check them a little earlier, just because that is considered a risk factor.
Yeah.
Is there a higher incidence in the Black community?
Yes, right, Dr. Yeah. Yeah, okay, so let's segue over in the time we have left over to the BPH, benign prostatic hypertrophy. And I always tell men these two diagnoses are very common, prostate cancer and BPH. The B stands for benign, so it's not cancer. A man can have neither, can have one of each, and can have both. But they're both very common problems. So how would you begin to approach this topic of BPH?
Right. So, basically it goes by symptoms. So, if a man has symptoms of, that are consistent with obstruction, so they have slow flow, they have difficulty either, starting the stream, or they get some dribbling, or, whatever it is. If they have some sort of issue that indicates an obstruction, that means that there could be an enlarged prostate. So usually, it kind of depends. If they have only mild symptoms, you don't have to do anything for it. It's a very common problem. 50% of men above 50 have this. 80% of men above 80 have these symptoms. So you don't have to do anything based on symptoms. Interestingly enough, the size of the prostate does not correlate with the symptoms. Sometimes you find, somebody has a 200-gram, average size prostate is 30 grams, right?
It's probably about the size of it. How big is it? A walnut? Is that the way it's usually?
Yeah, a walnut.
A walnut.
Yeah, so average, in someone who's, 50, 60 years old is about 30 cc's or 30 grams. But sometimes you can have someone with a 200-gram prostate. That's, almost 10 times the size, and yet they have no symptoms. Yet someone can have a prostate that's the average size and they have severe symptoms. So, the size of the prostate doesn't correlate at all to degree of symptoms. But basically, so based on their symptoms, if they have some, and it's bothering them, you can put them on medication. The most common one I give is Flomax. It's a very effective medication. Before it existed, a lot of urologists were doing surgeries for these things, and it kind of really reduced the number of surgeries that were being done, which is great. And it's tolerated very well. Pretty, mild side effects overall, although some people are bothered by those side effects. So there's other options. We have like these companies come out with these buzzwords. They call it MIST, or minimally invasive surgical techniques. So there's Urolift. Is it basically put in like sutures to open up the prostate, kind of like you're using a a hairpin or a curtain stay to open up, curtains. So you put a few pins in to open things up. That's one technique. And then there's another one that I don't personally do, but there's another one that is in the same domain called Resume, where you use steam to kind of shrink the prostate that way. And then there's the TURP, or transurethral resection of prostate, where we kind of use that same loop like we discussed earlier.
That's the traditional surgical treatment that I'm familiar with.
Correct. Yeah. So that's you take the patient under general anesthesia. You shave down the prostate. You usually have a catheter in it. It's definitely very effective. Traditionally, it used to be pretty bloody. I think we have improved optics and we improved technology to reduce bleeding. So even when I do this procedure, I usually send patients home. There's a variant of the TURP called the green light, which is a laser to vaporize the prostate. The benefit of that is that you can, send patients home. Although, again, I find you could send patients home with the other one too. But it's like a dealer's choice. So some people like to do one, and some people like to do the other. And then there's, for a very big prostate, sometimes you need to have something a little more aggressive. So there's something called a simple prostatectomy, where you traditionally it was done, with a big incision, where you kind of core out the prostate, like you're kind of like you imagine like you make a little opening in the orange, and you kind of peel the orange from the inside and pull it out, leave the shell intact. So that's now it's done more commonly with robotic surgery. Again, it's very effective for large prostates. That patients have really great relief on that. There's other things too. There's something called HOLEP, which is a laser to kind of do that same thing but from the inside. And that's the thing with the HOLEP is it's very specialized training, and there's not that many people that do that.
You told me when we were talking about this yesterday that you prefer the TURP over the green light, right? So do you think it's just a better technique? What's your take on that?
I'll do a little bit. I do a little bit of each. The green light for in terms of like the benefit of each. The benefit is that the green light has less bleeding. So that's one reason to do that. However, I think with the TURP is a little. I don't know if I want to say it's more versatile, but kind of depending on how you do it. I think other than that one night stay, it tends to have a little bit of a quicker recovery. I think it's kind of like I said, it's a dealer's choice. Whichever one you wish to do and you can do better is the one that you should do. I think a lot of people do both. I think I think that the TURP is just. I think the recovery is a little bit better.
I got you.
Other than that bleeding. So that other than that potential, as long as the patient is willing to accept a possible stay in the hospital for one night, I usually prefer the TURP.
From my perspective as a primary care physician, I'm, with elderly patients, men in their 80s, for example, I'm really trying to keep their medication regimen down to a minimal, even though Flomax, which is also called tamsulosin, is a great medicine. It does have some side effects. It can make men a little lightheaded when they stand up too quickly. And so sometimes I say, hey, maybe you are a candidate to kind of have this surgically fixed or corrected by someone like Dr. Stern. So I've been referring the patients for consideration of that.
Usually I'll talk to patients if they've been on Flomax. The reasons to do some sort of procedure, or if they have consequences of their enlarged prostate. So either they're not emptying their bladder, or they're definitely, if they have a catheter, they need something more, or even sometimes they're not quite there, but the amount that they're retaining is going up over time. That's another reason to do something. If they're getting stones in their bladder, that's an indication that their urine is kind of just sitting in the bladder and it's not being drained fully. Or if they get urinary tract infections, or if they're getting kidney damage. Sometimes, of having a full bladder and the high pressure of urination can actually transmit to the kidneys and damage the kidneys.
Yeah, it
can back them up over time. It's not common, so I don't want anyone to worry about that if they have this issue. it's pretty uncommon consequence, but it can happen.
I've admitted people to the hospital over the men with urinary retention due to basically the prostate. Usually it's an elderly man who may be in his 80s, but it's really kind of shut things off completely. He said it's not that common, which I guess is good, but it does happen.
Yeah, and sometimes you see it even in younger men too.
Right.
Prostate is one of the few organs that keeps growing over time. So, prostate just grows with each decade. It grows a little bit. So, and there's definitely a genetic component. So,
I wish we could switch the prostate with my hair. The hair could keep growing, and the prostate would stop growing. So our guest has been Dr. Michael Stern. You got to go to you're working today?
Yeah, I'm working in the Kingston office today.
Okay, great. I look forward to meeting you. He's a urologist in Kingston, also down in works out of down in Newburgh, right?
New Windsor.
New Windsor. And we barely even touched the subject, topic of urology, but we did have a great discussion. We're going to let you go now, though, okay?
All right. Thank you so much for inviting me.
So Dr. Michael Stern from Premier Medical Group. There's some other great urologists with his group as well, but he was kind enough to come on. So thank you very much.
All right. Take care. Have a great day.
Take care. Bye-bye.
Bye.
Okay, and you've been with us here at KCR, Kingston Community Radio, AM 920 and 92.5 FM. And we thank Dr. Michael Stern for updating us and enlightening us about urology in general. And we thank you very, very much. This last portion of Kingston Community Radio has been brought to you by Central Hudson. It is Monday, April 11th, and 33 degrees right now here in Uptown Kingston, and we'll be right back after these messages.
Forest animals, kids are coming to the forest, and it's up to us to make their visit a good one. Sparrow, have you practiced the most popular bird songs for the year?
Of course.
Catchy. I like it. River, how's the temperature?
It's a refreshing 52 degrees, man.
I love it. Turtle.
He's not here yet, man.
He's late every morning. Okay. Squirrel.
The forest has been preparing just for you. To learn more about cool things to do in the forest, visit discovertheforest.org. Brought to you by the U.S. Forest Service and the Ad Council.
Hey, Dad, your prescription will be ready in just a minute. Hey, Dad, your laundry will be ready in just a minute. Dad, your lunch will be ready in just a minute.
Hey, honey, why don't you take a minute? When you help care for a loved one, you give them as much time as you can. But it's just as important to take time for yourself. AARP can help. Find free care guides to support you and your loved one at aarp.org/caregiving. That's aarp.org/caregiving. Brought to you by AARP and the Ad Council.
Hi, my name is George Post from Ulster Park, New York, and I support Kingston Community Radio, and so should you. Where else can you speak to your local representatives on the air and have your questions answered? So thank you, and support KCR.
And we're back, and thank you for being with us here at KCR, Kingston Community Radio, AM 920 and 92.5 FM. It's Monday, April 11th, and it's 33 degrees right now here in Uptown Kingston. This upcoming segment of Kingston Community Radio is brought to you by Herzog's. Stop by Herzog's Home and Paint Center in the Kingston Plaza for all of your home building, maintenance, and painting needs, and discover the difference of buying local. And look at Herzogs.com. There are always ongoing sales. A little bit about the weather for the next 3 days in this surrounding area here, Kingston and the surrounding areas. Sunshine to start, then a few afternoon clouds today with a slight chance of a rain shower, 15% chance. Let's see if we can forego that. It's a high of 61 today. Monday night, tonight, rain showers this evening, about a 40% chance of rain showers with overcast skies overnight, a low of 46. Tuesdays, high of 70 with rain showers early with some sunshine later in the day. We've got a 60% chance of rain on Tuesday. A few clouds and a low around 40 for Tuesday night. And Wednesday, up to 69 degrees with cloudy skies. And Wednesday night, overcast with a little bit of rain showers at times. We can't seem to circumvent these rain showers. April showers. This upcoming portion of Kingston Community Radio is brought to you by Herzogs. And let's get back to the on-air studio, see if we've got some birthdays today, and
Are you doing the announcement first?
keep going. Yeah.
All right. Welcome to the second half of this morning's show. We had a wonderful guest on, Dr. Michael Stern, so we'll try to sum up that discussion. But we have some birthdays, Robin, don't we?
We do. There's 2 birthdays today. It's April 11th.
And what are we going to win, potentially?
A famous cow pie from Boy's Dairy Milk House, 62 O'Neill Street in Kingston. Have you ever had a famous cow pie?
I had a relatively well-known cow pie at one point.
I had one that wasn't quite famous, but
It's more obscure cow pie.
Delicious.
but they are
Not
still
famous.
amazingly delicious.
All right, so we've got 2 birthdays today. The first one is happy birthday to Joey Meyer. This is from your friends at the Girls Night Out Book Club.
Ooh.
And also happy 90th birthday
Wow.
to Marie Cook. And this is from your friends at the Town of Ulster Senior Club. Happy 90th birthday, Marie, and happy birthday to Joey Meyer. And drum roll, please. The big winner today is Joey Meyer. So Joey, just head over to,
Joey
go ahead,
Myers.
ring the bell. Head over to the Boys Dairy
We got
Milk
all our
House
equipment, right, Eric?
and tell them that you're today's big winner. And you can, I think you can either purchase a cow pie that's already made, or you can just have them add the ice cream that you want. I think you can make it up yourself.
You know
I
what?
hope I'm right about that.
You are absolutely correct. You can customize it. Yes.
And it's nice and sunny today.
It is.
You
It's
think
a
that
little.
the weather's going to be getting
Maybe about
warmer.
60, 61, but it's going to be warmer the rest of the week.
Stopping in at Boyce's on a warm summer evening is
Oh,
one
yes.
of my favorite
It
things
is very
to
nice.
do.
Yeah, it is nice. And we have an announcement here. Hello, Kingston clean sweepers and potential clean sweepers. Kingston clean sweepers and potential. Okay. Think spring. Yeah, I guess in the radio business, you got to remember to breathe, right? Robin's a singer, so
this
she
is the
remembers
famous
that.
clean sweep.
Clean sweep. I got
Yes.
it. Think spring. It has been a long, cold winter, and now it is time to get ready to clean our beautiful city. The Friends of Historic Kingston and the City of Kingston will be having our annual Clean Sweep event. So it is time to get your brooms and rakes ready and star the date on your calendar. The 13th annual Kingston Clean Sweep will be held on The Clean Sweep will be held on Saturday, May 7th, 2022 from 9 a.m. to noon. We sincerely hope you will join us, as many of you have done in the past. However, we are also reaching out to new groups so that you can join in our efforts to clean our community and show our pride. Mayor Steve Noble has pledged the support of the City of Kingston to collect the filled bags immediately following the event. So it doesn't quite say where and when to meet, but I guess there's more information to come.
More information to come. Yes, this is a yearly event and celebration.
Yeah,
May
of the
7th.
city. Yeah.
9 to noon.
Okay, so welcome to the bottom half of this morning's show.
Top half of the bottom half.
Well, the third quarter.
Correct.
We had Dr. Michael Stern on, a local urologist, and we talked about various topics. He's part of Premier Medical Group. They have an office in Kingston, and I also just want to mention that he does have some other colleagues there. It's a long name, and I don't want to mispronounce it. And that they all do, wonderful work there. And I encourage people to use local services if they are in need of a medical
Do you know
specialist.
if you have to be referred to the urologist or if you can just go if you want to?
We didn't really ask him. Of course, I'm going to give my bias, and I think that you should be referred. I came up with I'm really patting myself on the back, but I came up with a very good metaphor. I said sometimes patients think they need a service, but they're kind of wrong, and they will take the wrong exit on the thruway,
Right.
So you may or may not need a urologist. It's not a bad idea to consult with your primary care
At my
provider.
former medical office, we had specialists in the office as well. Some of them required a referral and some of them didn't. So, you might want to look into that and just make sure, too, with your insurance, if you require a referral, that you get that from your primary care doctor.
I like a referral because the primary care doctor knows what you're doing.
Good
Exactly.
point.
And also in my former office, just speaking from a rheumatology standpoint, some people think they might need a rheumatologist, but they don't. That's not the correct specialist. So, you might need a different specialty. So you want to make sure that you check with your primary care doctor first and know that you're going to the right specialist. So, and that's good for you and it's good for the doctor because you're not going to a long appointment and then finding out at the end of the appointment that you're not in the right place. So,
yeah.
Saves your time and saves the doctor's time.
I'm a busy guy. You always make the patient come in. I mean, for me to say, yeah, you're right. I mean, certain, things like a skin exam, someone wants to go to dermatology and they need, I just do think it's a good idea to keep your primary care provider in the loop. The name that I was looking for, because I do not want to mispronounce it, was, okay, I don't see it here. There it is. Dr. Vemulapalli. He's also a urologist in Kingston, available to see patients. There's Dr. Parker, Walter Parker has been there for many years. And then there's, I think, another guy named Dr. Petro. We have a lot of mutual patients together, but we barely touched on potential topics in that field of medicine. But we talked a lot about screening, the what to do if you're told you have blood in the urine, understanding that there's still some gray areas. We talked a lot about prostate cancer screening. Still kind of, it sounds like, we're in support of it, but we were trying to work within the confines of recommended guidelines. Right?
Right.
We talked about enlarged prostate, so we got a great subjects. So it was a good guest.
The prostate is such an interesting subject because it doesn't do much, right?
No. And for a small organ of the male genital tract, it has a minor role in male sexual function. Other than that, it's just a big pain in the neck. You're really big prostate, but no, it's a very common cause of cancer in men, and then it gets enlarged. And there's even other topics. It gets infected. That's called prostatitis. Sometimes it just hurts. That's called prostadynia. I mean, there are other topics within the prostate. So yeah, it's a big pain in the neck. I think you talk about like genetics and how we evolve. I don't know why we still even have the prostate.
What does it do?
It has a minor role in male sexual function.
What does it create sperm or
no? But it creates some of the secretions and volume of male sexual activity.
Oh, okay, all right.
The sperm is coming from the testicles, and then
right.
We didn't even talk about that. We didn't talk about testicular cancer.
Right. Yeah, there's a lot more to do.
Young men can get twisted testicles. I used to love that band, but the. It's called testicular torsion. You can get infection of this little organ next to the testicle called the epididymis. That's called epididymitis. So there's so much that
a non-dropped testicle.
What's that?
Non-dropped.
Testicle. Yeah. You undescended testicles. Yeah. Absolutely. So we. Things, other problems. I mean, we barely touched the subject, so maybe I'll keep notes and we'll have him back or one of his colleagues back, and we'll do part 2.
Well, there's so much to talk about.
There is. And I also, I'm not really a herbal doctor. I kind of think that people should eat healthy diets, and if they want to do supplements or vitamins, I'm not going to stop them. But generally, I feel that if you eat a good, healthy diet, you're pretty much getting enough in there. There's a few exceptions. We're probably not getting enough vitamin D. As you get older, vitamin B12 levels will kind of drift downward. But anyway, I sometimes recommend for men with mild symptoms of an enlarged prostate, a saw palmetto is an herbal product, an alternative product that actually some studies have shown benefit. It probably mimics the prescription product. So there are times where if symptoms are relatively mild or a man does not want a prescription product, I will recommend this. One of the few times I'll recommend something specific. Probably the other time is enzyme CoQ10. I'll recommend for people on cholesterol medicine to kind of help with some of the side effects. Anyway, you think we okay?
Yeah, who said that there wouldn't be enough things to talk about with urologists?
Well, you know, when I
such a bountiful subject.
When I force one of my colleagues to come on the show, to, you know, really, and you know, they sometimes go, "What are we going to talk about?" I said, "Trust me, we'll come up with stuff to talk about." I mean, we're barely going to touch the surface of everything you do. So that's really it.
Yeah.
These people spend 70 hours a week practicing their craft and their art and their science, and that is intense. That is incredible. You know, almost every doctor puts at least 70 hours a week into what they're doing, and how could you not? How could you not have something to say about your
70,
work?
70 hours on a busy week? It does vary. They study this. It does vary from field of medicine. You know, surgical fields tend to be a little more time intensive. You know, because covering urgencies and emergencies. You know, in other fields, like they used to use an acronym in medical school called the ROAD specialties were the ones that were desired because they were less demanding hours-wise, but still rather lucrative. So the ROAD stood for radiology, the O is otolaryngology or ENT, and the A is anesthesia, and the D is dermatology. Those are the famous ROAD specialties, although the O might also be ophthalmology. It's interesting. Anyway, but certainly urology is not on that list, and they work very hard. Yeah, doctors, I don't know how much, you know, I probably do between, around 60, maybe 70 hours a week. It's a lot of like intangibles. Like how do you really count hours at night spent on doing the computer work, which is basically the equivalent of paperwork.
That is definitely to be counted.
Yeah.
That is definitely to be counted. And Dr. Stanberg, I laud you for the number of hours that you put in to make this show possible.
All right. Thank you. Robin's my witness. Do I spend some time in that?
So happy to.
They call that pajama time, by the way.
Pajama time.
Pajama time. And it's not good, by the way. It's really weighing on a lot of physicians. Now, imagine a younger physician who has children, works a full day, comes home, dinner, maybe homework, or you're getting kids in bed, and then around 9 o'clock, we'll then log on the computer and work for 2 to 3 hours just to kind of wake up the next day and go through it again.
Back to that old discussion we always have about, being nice to one another, calling the doctor's office and being pleasant,
right?
As opposed to being demanding and feeling like you're not being taken care of. The truth is that your doctor has you in their best interests, for sure.
Remember, your doctor is on your side. I still see it from insurance companies. Basically, when they turn something down, the verbiage in the letter will say something like, "We are unable to approve this product because then it's
your doctor didn't do something right."
Right, your doctor did not give us the correct information, and so a lot of times they'll say they got nothing from us, which is rarely the truth. At first, sometimes it was we never knew to send it. Okay, that happens. But plenty of times it gets sent. They just kind of say no anyway.
Right.
It's a problem.
So we were going to segue into some springtime topics.
Yes. We were going to revisit some of our bread and butter topics.
Not too much Lyme that you're hearing about because it's pretty much overshadowed by COVID, right?
Right. Remember there's Lyme and then there's Lyme anxiety. So I think the Lyme anxiety, some of the COVID anxiety has kind of replaced that. But Lyme is common. I mean, I'm about to start a part of my year where I'm going to diagnose it frequently for about 6 months of my year. Kind of starting around now to mid fall, and occasionally even a case in the middle of winter. Ticks used to obey kind of a more seasonal pattern, but I think they're as confused about warmer temperatures as we are. And I, from what I can gather, if a temperature is greater than 45 degrees, the ticks are basically active. So if we're having a little bit of a warm spell in December, they might be out. So Lyme disease, I always, whenever I deal with it and talk to patients about it, diagnose it, I always plant in their head, intentionally, the idea that the great majority of Lyme disease is effectively and promptly diagnosed and easily treated. So I'm really just trying to, make the patient feel confident that they're going to be fine. Yes, there are some more challenging cases, more difficult cases. Generally, those are the exception. Most are pretty straightforward. So, Rob, what causes Lyme disease?
Tick bite.
Tick bites. Any particular type of tick?
Deer tick.
Deer tick. Yes, the deer tick. And the bacteria is called Borrelia burgdorferi. I don't know where the name comes from. It's related to syphilis, which is one of the things that kind of spurs alternative opinions about Lyme, because they feel that whatever syphilis does, Lyme could potentially do as well. It's controversial. Okay. And by the way, I'm going to acknowledge controversy regarding Lyme. But I think you should have faith in your physicians. Anyway, so it's caused by a bite from the deer tick. The tick will attach anywhere from 24 to 72 hours. The longer it's attached to you, the more likely it is to transmit Lyme disease. So the first order of business is to try to prevent tick bites, or if possible, remove them from your body as quickly as possible. So, the basic things regarding, by the way, it's great to get outside. People are doing gardening, they're walking, they're enjoying the beautiful Hudson Valley that we live in.
Definitely, Dr. Stanberg, pick your favorite Lyme and tick repellent.
Mm-hmm.
Pick your favorite repellent, put it all around your clothes and your feet, and make sure you have it on.
Right, and other things that are sometimes recommended, if you're going to go hiking, maybe wear long pants. I think it's a tough recommendation if it's the middle of July.
Yeah, but it's not unusual to use light socks, light-colored socks. I mean, I do it all the time. I pull the light-colored socks up over my pants.
Tuck them in
when we're in a hike.
Yeah.
Yep. Mm-hmm.
Fashionista.
Yes, then we'll have to.
Somebody posted the other day. This it looked like a cool tip. They use like a painter's tape, like how painters use that so that they don't get any paint on the trim.
Yeah.
So and they wrapped it with the sticky side out around their ankles, and then like the ticks were like if they were coming up, they were just stuck to the tape.
That is ingenious.
Yeah, it was
a
really cool tip.
Thank you for that. Thank you for that.
That's the tape out.
And that goes out to all our listeners.
Yeah.
Backwards painter's tape along your ankles, right?
I guess any kind of tape would probably work. I mean, as long as the sticky side was out.
Yeah, you could use Gorilla Tape.
Of course, you could come home and you've got like twigs and
tick tape.
You got sticks and twigs and everything stuck to your ankles.
All right, creative right there. Kind of like almost like a mousetrap for the tick,
Correct.
Yeah, so the deer tick is transmitted by the deer population. So that's kind of one of the explanations why ticks populations have gone up, because our deer population has gone up. I guess there's a disease that's affecting a lot of deer now. So who knows, what ramifications that might have.
Yeah, over the past year, it was pretty devastating. So the treatment for Lyme is still the same, isn't it? Antibiotics?
Yes, it's a bacterial disease, so the treatment's antibiotics. So let's review symptoms first. They will potentially occur, I always say 3 days to 3 weeks after a tick bite. It's probably not quite 3 weeks. That's probably a little unusual. And I also, a lot of times people get asked or they'll volunteer, I don't remember a tick bite, or the provider will ask that. I don't find that a helpful question. These ticks are small. These are the nymphs.
What are they?
Nymphs. There's 3 stages of tick life: the larvae, the nymph, and the adult. The larvae they're born, they feed, and then they molt, and they come back as nymphs, and then they feed again, and they have a little tick bar mitzvah, and they come back as adults.
That's good.
All right, now I'm joking about the bar mitzvah. They feed again and they come back as adults. So the nymphs are small. They're about the size of
like a pinhead.
Yeah, like a pinhead. And then when they feed, they engorge, they get much larger. But it's easy to miss these. And
they like to go where you're not checking, right?
Yeah,
like
kinda.
behind your knees and...
Behind your knees are probably the most common site.
In the middle of your back sometimes.
Small of your back.
You don't have like as many nerve endings, right? Back there you can't feel things as well.
Yeah.
Yeah.
Yeah, my cats get tick bites. My cats always get the tick bites on their neck because they are able to remove it or face. Every other way of the body, they're able to kind of, cats
take it off themselves.
Yeah.
And they also introduce an anti-pain, what do you call it, an anesthetic?
Oh, an anesthetic,
yeah.
right.
So you don't even know they're biting you for 3 days. And I remember once reading about research about trying to identify that and then reproduce it as an anesthetic we could use medicinally. I don't know if that ever went anywhere. But by the way, we already have pretty good anesthetics. So
creepy.
What's that?
It's creepy.
Creepy, huh? So it's the nymph, and so I don't find that a helpful question. I feel that the tick bite that makes someone sick did not get noticed. That's why it made you sick. Because if you notice it, you remove the tick, and it's probably not there long enough to transmit the infection. So behind your knees, in your groin, between toes, armpits, for women beneath breasts. You mentioned back or the buttocks, hair. Especially in kids, because kids are playing and they're rolling around, and so the importance of just being vigilant and doing a tick check on yourself, or for parents of younger children, also doing a tick check as well. So that specific question, I don't remember a tick bite. I don't find helpful. By the way, anyone who goes outside, and who goes into their car and brushes up against a bush while they're getting into the car, you could pick up a tick. So when people say, I'm in the woods all the time, that I guess increases the risk of tick bite, but we're all at risk.
So are you going to feel symptomatic? Are you always going to get a rash?
That's a good question. So when you evaluate the symptoms of Lyme, they're usually in primary, secondary, and tertiary stages. So the primary could be, and is divided more into two subcategories of early localized and early disseminated. So localized is this rash. It's typically called a bullseye rash. It's big. It's got to be at least 5 centimeters, which is about the size of a big orange. It could be anywhere from 10 to 15 centimeters. Sometimes I see it almost like go around someone's torso like a big pancake. They would kind of like you would kind of roll around someone's side there. Usually the tick bite is, other than being there, is not particularly symptomatic. It can be a little uncomfortable. It can be itchy. Sometimes it can get worse, even blister a little bit. But usually it's just something someone notices. They're getting dressed in the morning and they go, what's that? Or their partner or family member notices it behind their knee. I remember once a long time ago, I was at the county pool with my family and making small talk with a patient of mine. And then he walked away and I saw it in the back of his knee.
You had a big bullseye rash?
And then I called him back. I said, I think you got something there. It's important to note that testing for Lyme disease in that stage is not helpful and really not necessary. There's very few things in medicine that look like this bullseye
Got it.
rash. If it's present, that's enough to make the diagnosis. And that's an easy treatment. Actually, for years, we recommended 3 weeks of antibiotics. We're actually down to 10 days for this type of case. Some people are still not entirely comfortable with that, so they recommend 14 days. But you really don't need 3 weeks of it anymore under current standards. So that's early localized Lyme. Then you can get early disseminated, which is what it kind of sounds like. It's in your bloodstream now. So you might feel sick. You get fever, headache. It can make you quite sick. Fever, headache, swollen glands, achiness in your joints and muscles and bones.
Fatigue.
And then you actually can have multiple little bullseye rashes throughout your body in this stage of Lyme as well. Again, though, at that point, if someone has these symptoms without the rash present, you might want to do blood work. But early blood work still might fool you. You've got 1 minute to our break, so sometimes we do it early, make a decision to treat, and then for completeness sake, we'll repeat the blood work after treatment, even though it's kind of making the diagnosis in retrospect that's already been treated, just confirming it. And then so that's early stages of Lyme. That's the most common that we see people with. The second stages can be something called Bell's palsy, which is very dramatic. Bell's palsy is like when half of your face kind of becomes paralyzed. Someone wakes up in the morning and looks, it could be, and it causes symptoms too. It's not just something visual, but generally it's very obvious and dramatic, really, and very upsetting to patients. Frequently wind up in the emergency room. There's ways to differentiate it from a stroke, but that's always the possibility that this person have a stroke or they just have Bell's palsy. We're going to go to our last break of the morning, and then we'll revisit the subject.
Thank you, Robin Baker, Dr. Eric Stanberg. And it's now at the bottom of the hour, and you're with us on Kingston Community Radio, KCR, at AM 920 and 92.5 FM. It's Monday, April 11th, and 35 degrees now here in Uptown Kingston. This last portion of Kingston Community Radio was brought to you by Herzog's. Because the colors and quality of paint you choose matters, Herzog's Paint and Design Center, located in the Kingston Plaza, is there for you, offering the largest selection of Benjamin Moore paints and the area's most complete line of painting supplies. Herzog's Paint and Design Center also provides color samples from Benjamin Moore paints, including the eco-friendly Aura line. So see what matches up and works for your house. And color decorating consultants and expert interior designers are ready to assist you in choosing the right colors and more. Visit Herzog's in the Kingston Plaza. Spring cleaning. Herzog's is a great place to go for your equipment. And we'll be right back after these messages.
I was in the middle of the Atlantic Ocean when it happened. There was a sudden jolt and our submarine crashed on the seafloor. We were in total darkness.
That's Dr. Dejana Figueroa, a marine biologist and STEM teacher, talking about a deep sea dive she'll never forget.
It's funny, when I was a kid, I was afraid of the ocean, and there I was, 2 miles below the surface. But as a scientist, you prepare for that. Using our training and a little creativity, we fixed the sub and finished our experiments. The dive was just too important. Every dive gives us glimpses at things few people ever get to see. Glowing creatures, fiery undersea volcanoes. When we got back to the surface, I kissed the ground and called my mom, of course. But you know what? I wouldn't trade that dive for anything.
Dr. Figueroa uses her passion for STEM to discover new things and make the world a better place. She can STEM, so can you. Check out She Can STEM for more stories and inspiration. A message from the Ad Council.
Hi, this is Shirley Stabe from Kingston, and I support Kingston Community Radio, and so should you.
Thank you, Shirley. And you are with us here at KCR, Kingston Community Radio, AM 920 and 92.5 FM. It's Monday, April 11th, 35 degrees right now here in Uptown Kingston. Pretty sunny. And sunshine is going to be very much a part of today, with a few afternoon clouds. Slight chance of a rain shower here or there, with a high of 61 today. Tonight, rain showers this evening is about a 40% chance of rain. That usually means that there's something that's going to come by. Low of 46 degrees. Tuesday, we have a 60% chance of rain showers early with some sunshine later in the day. A high near 70. And Tuesday night, a few clouds, low around 40 degrees. Wednesday, cloudy skies, slight chance of a rain shower, high of 69. And Wednesday night, overcast with a 40% chance of rain showers at times, a low of 54. And this upcoming portion of Kingston Community Radio is brought to you by Ulster Savings Bank. Many locations throughout the Mid-Hudson Valley. Dr. Stanberg is making me laugh. Okay, so yes, many locations throughout the Mid-Hudson Valley and one near you, Ulster Savings Bank. Let's get back to the on-air studio for this last portion of Medical Monday. Welcome back.
All right, welcome back. Yes, Robin and I were clowning around.
You were making faces. You made Dan laugh.
Well, this conversation...
I couldn't finish.
Well, this conversation has got me ticked off.
Oh, it's the worst puns ever.
You see that movie about the ticks, tick, tick, boom, or...
Tick, Tick Boom.
Yeah.
By the way, great movie.
Oh, we love that movie. Andrew Garfield is very phenomenal in that movie. And we saw Coda over the weekend, too.
Yeah, good movie.
Yes, that was the one that won the best pictures. You know what it stands for, Coda?
Kid of deaf adults?
A child of deaf adults.
Child of deaf adults.
And it's about a young woman, high school senior, with deaf parents and a deaf brother, and they're all played by deaf actors, although she's not deaf, and it's really a wonderful movie. Very, very, I think everyone would appreciate this movie. And anyway, so we're talking about ticks. We were talking about it maybe causing Bell's palsy. It can cause. These are the second stages. It can cause a type of meningitis. Can make people quite sick. This is when it gets tricky. The way you make that diagnosis is with a lumbar puncture. But as I tell patients when they get this, at that point it's usually maybe a hospital admission. They're going to be fine. All right, we'll get to treatment in a bit. And then you got late stages of Lyme. One is probably a type of arthritis, usually in the knee, where the knee gets really very swollen. When I diagnose that, I say to patients, boy, I'd almost rather have you have Lyme rather than telling you have end-stage arthritis and you need a knee replacement, because we'll treat your Lyme and then, for the most part, you're going to get better. Anyway, that's just me kind of putting a spin on things for patients.
Have you noticed any relationship between Lyme disease and ALS?
No, but there's controversy and there's research. The difference between research and controversy. Research is fine. The whole idea is Lyme. Does it affect the immune system? Have you heard about that? Has anyone mentioned that?
Yes.
We know very little about ALS. It's a horrible, horrible condition. That's amyotrophic lateral sclerosis, commonly referred to as Lou Gehrig's disease. It's probably a combination of genetic predisposition and maybe an infection that kind of triggers the immune response. It's thankfully a rare disease, and we really don't have treatments for it. It's a chronic, progressive condition that will result in someone's demise, unfortunately. It's a dreaded diagnosis. Whether or not, any infection, if you want to believe the immunologic theory, anything could potentially then trigger the immune cascade that will lead to this. We're going to have a neurologist on in a couple of weeks. Maybe we'll revisit that subject. Okay, so... And then, is Lyme, for example, linked to dementia? It might be. I mean, a lot of neurologists, geriatricians, or just primary care physicians might include a Lyme test as part of the workup for memory impairment in various patients. So treatment is really pretty straightforward in most cases. We use 2 antibiotics. These are basic antibiotics. There's nothing fancy about these treatments. The first choice is usually doxycycline. Doxycycline's been around forever. The second choice is amoxicillin. Again, been around forever. Doxycycline is probably the better choice. It kind of permeates into your nervous system a little bit better, so theoretically prevents things like Bell's palsy. And it also cross-covers some of the other tick-related illnesses that have very similar symptoms, like ehrlichiosis and anaplasmosis. Minimal 10 days, 14 days. It's, when you have a later finding like the Lyme arthritis, the treatment actually might be 21 and probably even 28 days of antibiotics. When someone has something like Lyme meningitis, when it's in your nervous system, the treatment is another antibiotic called ceftriaxone. The brand is called Recefin, and that's an intravenous medication that someone will have to receive. And it's only once a day, but for a month basically. So. But that diagnosis, at that point, I would not make that diagnosis. At that point, it's either the patient's been ill enough to be hospitalized or symptoms have been persistent and I have referred them to an infectious disease doctor or a neurologist to help make the diagnosis. All right, so doxycycline you have to be a little careful about in the spring and summertime because it can cause a very bad sunburn. So sometimes I'll choose amoxicillin if someone, for example, is a farmer and they're, no matter what I tell them, they're going to be out in the sun all day, so I'll say, fine, they'll go with amoxicillin. I remember a truck driver who was put on doxycycline came in with his left arm was red and, bright from driving with his left arm out. You know, so he thought he was following instructions and avoiding excessive sun exposure, but he had his arm out. So anyway, that's just one of the things to worry about with doxycycline. They used to worry about doxycycline causing dental problems in kids for years. Don't give it to kids. Don't give it to kids. Guess what? We've now kind of changed our mind about that. And doxycycline is okay to give to kids. The idea of what's called tick bite prophylaxis should be discussed. You know, a lot of people, you know, not every, to be honest with you, the great minority of tick bites lead to Lyme disease. I don't know. I can't give you a number, but certainly less than a third will lead to Lyme disease. And again, it depends on how long it's been attached, whether it's engorged or not. And there was a study at this point, it's about 20 years old, that looked at giving a couple doses of doxycycline after a tick bite and whether that prevented Lyme disease. There are a lot of caveats to that diagnosis. I'm sorry, in the study, in the recommendation. They did show a benefit, but it had to be identified as a deer tick. It had to be present, attached for about 36 hours. I don't know how, you know, it's like a little tick hotel where they check in at a certain time. You know, I mean, you don't really know how long the tick has been attached there. Anyway, so a lot of caveats with that, and I, you know what, I can identify a deer tick. You know, I used to have a microscope in my old office. We would take the tick and kind of put it on the slide, and there's certain ridges and ways to identify it. But when they get engorged, they all kind of look alike. These big, fat, bloated, bluish things. They're kind of they're really pretty gross. So I find that a tough assignment to give to a patient and say, well, can you prove it was a deer tick or not? And they're going to say, no, I don't know. I'm not an entomologist. I don't know about this. Is that what who studies? I think entomologists technically.
You nailed it.
What's that? I nailed it?
You nailed it.
Well, I think they technically study insects, and to really be annoyingly detailed about it, the ticks are not insects. What are
arachnids?
They're arachnids. Still just as creepy, though.
Yes, I don't like them.
So they're related to spiders and scorpions and mites, but they're technically not insects. Anyway, so we've really gotten very liberal with prescribing the tick bite prophylaxis to patients, but probably to an excessive degree. I get bit by ticks. I live in a wooded area. It's Ulster County, and for the most part, I just take them off. I don't put myself on antibiotics. That's my own approach to it. All right, so when should you get tested for Lyme? Some people will, say you get bit by a tick and they'll go to urgent care, which is probably not a necessary use of healthcare resources. And sometimes, I know this because they contact me, they're told that they should get a Lyme test 3 to 4 weeks after the tick bite. I don't think that's necessary. I always ask the same question. What symptoms are you having? I want to know how you're feeling. If not, I don't recommend testing. Because then you're just treating a test. Someone could be positive for something that happened decades ago. You can get Lyme again and again, which makes it hard to diagnose with blood work because you don't know whether you're looking at remnants of last time's blood work versus a new infection. That is a challenge of Lyme. Any questions?
No. I find this subject very interesting. I think that it's hard to not want to be tested, as a lay person. If you get bit by a tick, you do
but that's
err on the side of caution, make sure that you're okay.
It comes down to a longitudinal relationship with a primary care provider that you trust.
I have a question.
Yes.
Okay, and this might go way deep into whatever Lyme is and how it's been spreading across the country, but I remember being in the forest, in the woods. I lived in the forest and the woods in my, I was born in 1954. We had a woods behind our house. I traversed across the West Virginia forests like mad, all around western Pennsylvania.
What state?
Pittsburgh.
Okay,
Pittsburgh
right.
area, yeah. And there was no such thing.
Yeah, of ticks, you mean, or Lyme?
Lyme. There was no such thing. I got Lyme at 50.
Do you remember being bit by ticks when you were a kid?
I don't remember seeing ticks ever.
Yeah, and I don't either. And I grew up in Jersey, basically, but I was a kid in the woods and playing. No, the tick population has increased. This is an interesting discussion. When I've spoken to some friends about this, they think some of it has to do with development. That you're taking a population and you're kind of, squeezing them into more dense areas.
With the deer.
Yeah, the deer,
Also.
and then the deer population increasing as well. Has kind of led to these tick bites, but I grew. I
can follow that. I can follow that. Okay.
I'm sorry.
I understand what you mean there. Yeah.
But this is interesting topics for friends of mine who are really into they talk a lot about cluster development. I remember when I lived in New Paltz, they felt that yes, communities are going to grow. It just happens. But rather than every house being on 3 acres, they felt that the community should just kind of grow at its perimeter. Here's another house, here's another house. So, and the idea was to keep the other properties kind of preserved, rather than kind of divvy it up.
Right.
Anyway, so tick population. So Lyme was not really even discussed in the mid '80s. It did. Borreliosis did exist as an illness as well, and actually in Europe. I don't know why. Why does anything show up? Why did COVID show up?
Yeah. I think it has a lot to do with the fact that we're much more interconnected with travel and things like that.
That's true too. The idea that these things are not really regional. I think we talked last week about spider bites. How the spider hops a ride on some 18-wheeler truck, and now it's in New York. So that's something to consider. So. Tick bite prophylaxis. If you have a higher risk tick bite, your doctor may offer you that. It's usually 2 doses of doxycycline taken within as soon as possible after the tick bite. It's more likely to be effective, but you really should be within 48 hours of removing the tick. Might prevent you from getting Lyme. Sometimes if someone can't tolerate doxycycline, we'll extrapolate that and give them amoxicillin. But as long as we understand that, the studies were done in doxycycline, if someone says they have an allergy to it or whatever. So what are some of the controversies regarding Lyme disease? Mostly it's about whether or not it causes chronic symptoms. And if it does cause chronic symptoms, does that therefore mean that someone should be chronically treated for it? And this is really where the controversy comes in. People can have bad cases. For example, if you have Lyme arthritis and we treat it, overall the arthritis will improve, but you might be left with some joint damage there. It's an infection. It's affecting your knee. Is it going to potentially damage your bone and cartilage? The answer is yes. So whenever you have a major problem, you're going to potentially have some chronic symptoms. When I deal with a patient who feels that they have chronic symptoms of Lyme, I don't disavow their symptoms. I do usually offer an opinion that I don't recommend long-term treatment with the antibiotic. I think it probably does cause some chronic symptoms. They're hard to measure. The whole idea of brain fog. What exactly is brain fog anyway? How do you diagnose that?
Right. Well, you used to be clear, not clear anymore.
Yeah, but it's subjective. We have a caller. Good morning.
Oh, good morning. You hear so much about the tick bites, with the Lyme disease, and being there's such a large population of the deer. Are they working on any kind of a vaccine for this, by chance?
Good question. There was a vaccine that was briefly out in the late 90s, and it's an interesting story because it got taken off the market. So, when they develop a vaccine, gazillion dollars get put into this. And they just quietly took it off the market. The rumors were that it was associated with actually triggering Lyme arthritis. It was never really forthcoming. So since then, I don't think there's been any major work in developing a vaccine for Lyme disease. Generally it's a bacterial illness. Contrary to what people say, it rarely is fatal. There are some cases. We didn't really talk about Lyme causing slowing of the heart. When there's fatal cases, it's usually that, and they were early on before it was identified. So I'm not really aware of. I think that we should probably prioritize fine-tuning our COVID vaccines, and just continue dealing with Lyme as we are right now.
Yeah, because I know there used to be a caller, she's deceased now, who did have the Lyme disease, and I remember she really had it bad. And I know she would call in every once in a while, and push for some kind of a treatment for it that was, she hadn't given it. Like I said, she was really badly affected from the Lyme.
A caller from before. Yeah, some people, it does happen because you saw it in the infectious disease office. Like they need diagnosed with a lumbar puncture, like you said, and,
Right.
It's like a neurological Lyme.
Yeah. But even those patients carry, if it's diagnosed in a timely fashion, they carry a very positive diagnosis. So I'm not really aware of any major work being done on a Lyme vaccine right now.
I'm impressed that there's a Lyme vaccination for our dogs.
Interesting. I have no idea. Again, beyond my purview. The standard is a little bit different on humans versus dogs, and maybe it's the same vaccine that was kept on maybe that's why they pulled it off the market, saying, okay, well, forget about the potential bad press we're going to get in humans. Let's just focus on the dogs. There's a lot of business and marketing going on with these things. But
okay, so thanks very much for
all right,
that.
well, thanks for listening.
I really enjoyed the show very
All right,
much.
great. Thank you.
Thank you.
Have a great day.
Wait, you want to say something?
No.
You were smiling.
I'm just smiling. I smile.
Another symptom of Lyme disease.
Have you seen any poison ivy yet?
Oh, with 9 minutes left, you want me to talk about poison ivy? No, not yet.
I'm spending a lot more time outside, and I'm not sure if I could recognize poison ivy.
Well, it's not really out yet, but what is out is this time of year people are clearing brush, they're cleaning up from a long winter, things that maybe weren't cleaned up in fall. So you might be picking up like a log, for example, that back in August was covered with poison ivy. So it's called a resin, might still be on that. So that's why you can get poison ivy any time of the year. Yes, it is more common in spring and summer. I see it in wintertime from Christmas trees.
It's very common in the fall, too. That's when it's really resinous.
Right.
Yeah.
So firewood, So
Wasn't there a shot for poison ivy at one time?
I think that story, because people do ask if they can have a shot. So when the treatment for poison ivy is usually steroids, most commonly prednisone. Now, when steroids became a commonly available tool for doctors, they like in the 50s and 60s, before they were in pill form, they were in injectable form. So that's where that comes from. When someone says, "Can I have a shot for my poison ivy?" Because there was at the time where that's what was given, but that really has been replaced by pill form, and you really want to do the pills anyway. It's a type of allergic reaction that can kind of last. So if you don't do enough treatment, the treatment will wear off, and then you'll get a rebound, make it even worse. So poison ivy most of the time should be treated for 10 to 14 days with a certain regimen of prednisone to really.
And the steroids reduce the inflammation?
Yeah, inflammation. It's an allergic. It's a type of allergic reaction. It's called a delayed hypersensitivity reaction. So it occurs probably about 3 days after you're exposed. So that's an interesting point. So if you're cleaning your yard, you should be wearing gloves. You should be wearing a long sleeve shirt. It's not even that warm anyway. And try to protect yourself. And then you want to wash your hands as soon as possible. It's a little off-color subject, but I've seen some very bad cases of poison ivy in someone's private area because people go to the restroom and then they wash their hands after they go to the restroom. So if you're working outside, I recommend you wash your hands before you go to the restroom, because to prevent that from happening, because you talk about uncomfortable.
Right. And try not to touch your face and your eyes.
Right. You're working outside. I don't know if it's a visual. You kind of do stuff like this. You
wipe the back of your head.
Yeah, you get a little sweaty or your hair's in your eyes. So you got to try to avoid stuff like that because then it could be on your hands and now it's on your face. And it could be bad. In more severe cases, it can make someone feel sick, causing, kind of an illness, fever, and just like being sick with something.
any good things come out of COVID might be the one that who didn't realize how much they were touching their own face all the time. Because I had no idea how much I touched my own face, but now I know.
Yeah.
So interesting.
I have a friend who eradicates poison ivy for as a landscaper.
As part of his living, you mean?
Absolutely.
Okay.
And now the precautions that they take are enormous. Taped hazmat suits, and they're in there getting it out for people's residences and their yards and their fields and things like that.
Is somebody local?
Yes, absolutely. I'm not familiar with the name of the organization, but you can find it here in Kingston.
Is it actual poison?
Poison ivy?
No.
In the poison ivy?
How do you define
poison to us, right?
Yeah. We feel poison. That's a good question.
Is it like an oil, a resin? What is it?
It's an oil. It's called urshadiol.
Wait.
Urshadiol.
Spell that.
Oh gosh. I'd be like one of the kids on the spelling bee.
Look that up.
Yeah, URSHODIAL. Urshadiol. It's the national spelling bee right now. Anyway, it's a resin, so it's like an oil.
You win, and that's been a great spelling bee day.
Is this a real word?
Yeah.
Urshadiol?
What?
Urshadiol.
Urshadiol. It's a constellation of a big. That's Ursa. All right, I was trying. It didn't work.
And that just means that it has like a resin or a.
Yeah, it's an oil. So it does kind of permeate into a surface, like some brush that's been underneath snow and ice for the winter. Urshadiol.
In the meantime, I've heard of poison sumac.
Yeah, that's a good point worth making.
That seems to be extraordinarily rare. I've never even encountered it.
There's you always talk about poison oak. So there are other plants
poison oak,
that cause this reaction, and that kind of has led to. People sometimes feel that poison oak and poison sumac are worse, right? Than poison ivy. They're all just kind of the same. Poison ivy is just a lot more common.
They all have the urshadiol.
Yeah, I might be wrong with that. I think I'm not remembering this correctly. I'm sorry about that. Look it up.
It's an impressive word.
Poison ivy resin. And the answer is Urushiol. Urshadiol is actually a medication that's used for gallbladder problems. There, you see it right there?
Okay.
Yeah, that's it. So it's URUSHIOL. Urushiol. Okay. Urshadiol is a medication. It would be awfully close. Glad I didn't prescribe. Whoops. Anyway, so be careful with the poison ivy. Remember, so what can you do if it's a milder case? You don't have to seek medical care. First of all, if it's itchy, and it will be itchy.
You put calamine lotion on it?
Well, you could. Okay, there's kind of two parts of the treatment. One is maybe if you need an antihistamine to help with the itchiness. Because remember, people kind of make it worse. They'll dig at it, they can't sleep.
And if you touch it and itch it, it can make it spread?
I don't know if that's really true. I know people say that, 'cause remember, so it's a delayed reaction from around 3 days ago. So you probably have bathed in that time. So by the time the rash is showing up, it's really off your skin. It was just there long enough to cause the problem. So if you scratch it, you're not really spreading it. But what's happening is various crops are popping up, and they're kind of doing it in the order in which they were exposed.
And if you scratch it, then it's not going to heal.
Right, and then you can, that can be bad. You can get just a type of eczema. You can get a secondary bacterial infection.
So you mean take some Benadryl to just...
If you're really having a hard time with the itchiness, you're going to want to take an antihistamine at some point. I usually recommend trying something like Zyrtec or Claritin or Allegra first. Benadryl works, but it's very sedating. So it's helpful at nighttime if you can't sleep, and itchiness is worse at night. Then you want to maybe do some form of topical treatment. You could do something like calamine, which is just a cream. It's soothing. It dries it up. It's a very moist type rash. You could do an over-the-counter hydrocortisone cream, not ointment. You could do that as well.
Because you want to dry it, not make it wet, and that's the difference between cream and ointment, right?
Correct.
We used to use egg whites, which wasn't that bad because it actually helped to dry it.
Interesting.
Very interesting. Yeah, we used to use egg whites. That was
I
kind
don't
of
know.
a wives therapy.
There's an adage in dermatology where if it's moist, you dry it, and if it's dry, you moisten it. So typically your poison ivy rash is moist and goopy, so you want to dry it. So you want to use a cream. Ointments moisturize, so just be aware of that over the counter. So, but if your case is more severe, you might need a prescription cream. There are stronger creams, and you might need some steroid or prednisone, particularly. So in that case, you should seek medical care. If it's on your face, you don't want to put the cream on your face. It can cause some problems. So, all right, we are going to call it a show.
See you next week.
Next week.
Thank you, Dr. Michael Stern.
Thank you, Dr. Michael Stern.
Thank you,
for a
Dr.
wonderful
Eric
show.
Stanberg. Thank you, Dan.
All right. Thank you, Robin.
Thank you, the Maxwell family, and we'll see you next week.
Next week. Have a good week. Bye-bye.
Okay, and thank you. And you've been listening to KCR, Kingston Community Radio, AM 920 and 92.5 FM, WGHQ, and our live streaming on mykcr.org. Talk radio at its best, inspired discussions of, by, and for the community. Monday, April 11th today, 36 degrees as we're closing up shop here. And this last portion of Kingston Community Radio has been brought to you by Ulster Savings Bank. Many locations throughout the Mid-Hudson Valley, one near you. We invite you to be with us for a terrific Tuesday tomorrow morning at 7 a.m., 7 to 9 a.m. every weekday. KCR, Kingston Community Radio, on WGHQ AM 920, 92.5 FM, and streaming online at mykcr.org. And until tomorrow, we wish you every success in growing and developing Kingston and all our neighboring communities. We now return you to Magic 92.5.